stretch law? Starling's law says the more I stretch that left ventricle and engage the muscles, the greater the rebound force, which creates cardiac output. It's kind of like a rubber band. If you pull a rubber band back, the further you pull it back, the more forward velocity it's going to have. So when the left ventricle fills, it stretches, the muscle contracts back, that's where the cardiac output goes. There are tendons on the valves, on your toilet paper my ass, tricuspid, pulmonic, mitral, and aortic valve. Those tendons hold the door shut, so to speak, that allow the vessel or allow the heart to fill with blood and stretch. Anybody know what the tendons are that hold the valves closed? Chordae tendineae. All right, so what happens is that's our normal cardiac output. In the pericardial tamponade, if there's blood in the pericardial sac, that left ventricle can't fill with blood because the blood in the pericardial sac is pushing against the left ventricle. Because it's pushing against the left ventricle, it obstructs blood flow in and out. As a result of that, I still have preload and diastole coming in, but I can't eject enough blood out. That's why the systolic will go down and the diastolic will stay the same or slightly elevate. That's where we get the narrowing pulse pressures. Because of blood in the pericardial sac, that creates muffled heart sounds. So narrowing pulse pressures, muffled heart sounds, and if blood's coming into the heart and it can't leave and it backs up, they get JVD. The subcategory of shock this is obstructive shock, because I'm obstructing blood flow in and out of the heart. It's not enough blood loss in the pericardial sac to cause hemorrhagic shock. Matter of fact, pulling anywhere from 15 to 30 cc's of blood out of the pericardial sac will fix them a lot of times. So we're talking just one big syringe full of blood will help reverse that pericardial tamponade. That's called a pericardiocentesis. Definitively, that is what they need. We are not going to do that in back of an ambulance, though. The problem with it is if you go too deep and hit the left ventricle with the needle, it can put them into VFib. So you can imagine bouncing down the road. Oops. So that's why it's not a paramedic skill according to the registry. Some of the flight medics in the area, there are some local fire departments that allow their personnel to do pericardiocentesis, but they already have to be dead from blunt trauma, right? But that's not a registry skill. Once again, just like we talked about yesterday, definitive means ultimately what do they need from the hospital, not necessarily us. Definitively, they need a pericardiocentesis. The narrowing pulse pressure, muffled heart sounds, and jugular vein distension. Remember, we assessed jugular veins at what degree? At 45. Those three things are what we call Beck's triad, right? Beck's triad. They may also have what's called pulseless paradoxis. Pulseless paradoxis, when they take a breath, the left lung inflates and it pushes in on the left ventricle. Well, because there's blood in that pericardial sac, when the left lung pushes in, they have no cardiac output, so they'll literally skip a pulse when they take a breath. That's why it's called pulseless. And then paradoxis is opposite movement, kind of like paradoxical movement where the rest of the chest would go out and the flail segment comes in. Well, when that left ventricle is trying to fill with blood and the left lung pushes in on it, that makes their pulse go away. That's why it's called pulseless. And then paradoxis. They'll skip a beat when they take a breath. Not much we can do for it. We also have to consider other type of injuries. Yes, sir. In the top of my,
I don't want to go all the way back to football.
we'll send one of them. In the top of my
And you got a pencil?
kid ends. Yes, sir.
You have a pen?
Just one. That's a pencil?
Oh.
That's a pen,
There's a pencil there.
I was gonna say, if nothing else, send it out of my office. The registry box, when you're standing at my desk, it's inside my cadenza on the top left.
Cadenza.
Yeah.
Credenza.
Whatever. You know what? Hey, from a guy that admitted just a scoosh.
Skosh.
Yeah, scoosh.
That little Bastard, he mispronounced it.
Scoosh. 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 Shave your head and walk backwards. It'd be prettier.
Yeah, now he found one.
Who was it?
Fucking Dallas guy.
It had to be more specific.
It's not the tall, it's not the skinny one, thank you. It's the kind of chubby one.
Let's see. All right. I don't even remember where I was at after that. Oh, whatever's bruised on the outside, we have to consider bruised on the inside. So if they have a bruised over that left chest wall, we're going to have to be concerned not only with the pericardial tamponade, but also a myocardial contusion, which is a bruising of the muscle, not to be confused with blood in the sac, which is pericardial tamponade. We also have to be concerned with if they have internal bleeding or chest injuries as well. So that's why anytime we have blunt trauma to the chest, it has a high risk of mortality because of the lung structure, the vascular structure, the heart muscle. There's all those different things that are vital organs within that area. Yes, sir.
And that cause ST elevation on all leads?
Yes, and that's what will happen is you'll see ST elevation in all leads. So typically on a 12 lead, if I'm ST elevation over here in my inferior leads, I should see the upside down picture, which would be depression on the lateral leads. So whatever's elevated on the left should be depressed on the right. Whatever's elevated on the right side of the 12 lead should be depressed on the left. That's that reciprocal or upside down image. If you have ST elevation in all leads, that usually has something to do with either pericardial tamponade or myocarditis. Myocarditis is basically a bacterial infection in the myocardium itself. But in order, if it was a heart attack, to have ST elevation in every lead, you would have to have every coronary artery blocked simultaneously at the exact same moment in time.
Jesus.
Probably not possible. All right, but yes, you will. If you see ST elevation in all leads, it could be pericardial tamponade or it could be myocarditis or pericarditis. Pericarditis and myocarditis are basically infections in the pericardial lining or the myocardial lining. The difference is a lot of times they'll have like a friction rub when you listen to it. The heart, like if you take your fingers and you put it by your ear, that rubbing sound, they'll have a friction sound, or they'll have that plus sharp chest pain and a fever. It hurts to breathe, hurts to cough, because anytime they put pressure on that inflamed muscle, they get a sharp pain, right? So that's that pericarditis or myocarditis. But ST elevation in all leads is a pretty good indication of that. So if they said you have severe sharp chest pain, low-grade fever, and ST elevations in all leads, they're pointing you towards pericarditis, right? And any of your carditises will do that. Endocarditis, myocarditis, or pericarditis, which are all just basically a muscle infection. We actually had one of our captains have pericarditis, and they ended up kind of crazy, but it developed scar tissue. So they had to go in and shave his heart a couple years later, which sounded pretty weird, but they described it as like taking a tomato and then barely shaving the outer skin of it. And that's what they had to do to get rid of the scar tissue on his pericarditis. He always blamed that for him being fat and out of shape. He's just a dick. So, if any of you guys know Kenneth Boozer, you can tell him I said that. He's retired now, but he's a dick.
Sir,
Yes.
the what's the other one? The ventricular fucking aneurysm. That will also create that whole ST elevation all over the place.
What now?
Like a ventricular aneurysm.
Like if the left ventricle, like if the wall blew out, or like
Yeah,
a
like-
vessel completely ruptured?
Like if it blew out, it's kind of like.
I have no idea, sir.
Okay, well, okay.
I have no
I didn't know if that
idea.
was important. Fuck.
I would say it's not meat and potatoes.
Okay, great.
So, yeah.
I don't need to learn it.
Yeah. No. You got too much stuff in your head, Montez. But yeah,
Most of this shit's not even useful though.
Yeah.
I'm aware. No, I've never heard of that, but I'm not going to say it doesn't exist. I don't know everything.
It doesn't exist. If you don't know about it.
No, that's not true. There's a lot of stuff I don't know. I know meat and potatoes. I'm not a big dessert guy, but give me some bread and steak and I'm good. So, all right. So are we good on pericardial tamponade? Obstructive shock. Flail segment is 2 or more ribs broken in 2 or more places. Some textbooks say 3. Well, 3 is more than 2. All right? So 2 or more ribs broken in 2 or more places creates the paradoxical movement. The biggest concern we have with the flail segment is inadequate ventilation. How do I know if somebody is ventilating or not?
Chest rise and fall.
Chest rise. It's real simple. Either the chest is rising adequately or it's not. Depending on the size of the flail segment will depend on whether they're able to ventilate or not. If the chest is not rising, you need to make it rise. How do we make the chest rise?
Bulky dressing.
Positive pressure ventilation, which is either mouth to mask, 2-person BBM, manual trigger device, or 1-person BBM. We have to make it rise and fall. How do we split a flail segment if they're alert, conscious, and can follow commands?
Bulky dressing and support or pillow.
Alert, conscious, and can follow commands. Use their own arm and hand. We'll do that before we do a bulky dressing or pillow. Here's why. If you hurt your ribs and you can self-split, you'll put enough pressure on it to make it feel a little better, but not so much pressure that you push the rib ends in and potentially create a pneumo. All right? If they can't follow commands, then we look at using a bulky dressing, pillow, something like that. We do not want to take them down tight or wrap them with an ACE bandage. Why do they do that at the hospital, but we're not allowed to?
Is there anything to do with the monitor or from inside?
And they can take a what first? X-ray. So they can take an X-ray to see if we take those ribs down, is it going to push into the pleural lining and create a tension pneumo or not? We don't have that ability. So they won't wrap them tight and band them until they do an X-ray. All right? Because if we do push anything in there and the rib ends are displaced, it could end up causing the pneumo if we're not careful. All right? Now, just because they have diminished breath sounds is not enough for a flail segment to create a tension pneumo. All right? Diminished breath sounds is not a tension pneumo. It can be the start of it, but a diminished breath sounds by itself is not a tension pneumo, even in a flail segment. They should be diminished because it hurts to breathe and the ribs are broke. Did you have diminished breath sounds in asthma, pneumonia, bronchitis? Those could all be diminished, right? But we don't dart them, do we? Just because it's diminished doesn't mean we have to dart it. I would expect a flail segment, broken ribs, or pulmonary contusion, a bruised lung, to have some sort of diminished breath sounds. Now, if it starts becoming where they're extremely difficult to bag and develop JVD, now we're becoming a tension. But diminished by itself is not enough to needle decompress somebody. All right, especially in the flail segment.
That'd be a simple.
It may not be a simple. A simple will have diminished breath sounds, but a flail segment, because they don't have rise and fall of the chest, can end up causing diminished breath sounds without actually causing a pneumo. A simple is a hole in the lung. If the hole's big enough, it turns into a tension. So if we look at a just diminished breath sounds by itself, it just means there's not enough air flowing in and out. Could be because of asthma, pneumonia, bronchitis. Could be because the ribs hurt and they can't take enough breath. That's diminished breath sounds.
I think I saw like it was a simple pneumonia and attention. I thought you said like you have to do like one.
When a simple becomes a tension, they get JVD, tracheal deviation, and the breath sounds will become absent. In order for a simple pneumo to become a tension, the hole has to be how big in the lung?
2/3 the glottic opening.
2/3 the glottic opening, which is roughly the size of your pinky. All right? So we need to look at those three things combined. We need to compare a hemothorax versus a pneumothorax versus a tension. In a hemothorax, what happens is they tear the thoracic lining and tear the lung, and they start bleeding to death inside their chest cavity. When they bleed to death inside their chest cavity, they're going to have hemorrhagic shock, and their neck veins are going to collapse. So instead of having JVD, they'll be flat. Okay? So they'll have flat neck veins, signs of hemorrhagic shock, and internal bleeding. They will also have what's called hypo-resonance breath sounds. Hypo-resonance breath sounds are a low or dull sound because there's blood in there, and that's usually a hemothorax. So hyporesonance means there's blood because there's a hemothorax. So what it basically is if I have my left lung filling with blood, and I was to move my stethoscope 2 inches over to the right, and I percuss, it's going to be muffled because of all the blood that's in that chest cavity. Versus hyper-resonance, it's not muffled at all because there's no blood in there, it's just air. So if you go to percuss and it's muffled sounding, that's hyporesonance, that's indicative of a hemothorax. If you go to percuss and it's as loud as you're tapping or louder, then that's air because there's nothing there to dull the sound. Does that kind of make sense? So a hemothorax is hyporesonance. Hyper-resonance, and I say it wrong on purpose, hyper is because there's air in there and it's a tension. Now, not all pneumos are a tension, okay? A hemothorax is blood. A spontaneous or traumatic pneumo just means that they have popped a hole in their lung. If the hole is smaller than their 2/3 of glottic opening, it will not turn into a tension. All right? So if you've ever heard somebody say they had a punctured lung, but yet they didn't have a tension pneumo or require a chest tube, that's because the hole was small enough that it stayed in what we call a pneumothorax. Spontaneous is without trauma. A traumatic pneumothorax is from trauma. Tall, thin males are prone to spontaneous pneumos. Tall, thin males from yesterday were also prone to what? Aneurysms. Thoracic and abdominal. So if I said you have a 27-year-old tall, thin male, right then you need to start thinking either spontaneous pneumo or aneurysm. So I say 27-year-old male, 27-year-old tall, thin male, sudden onset ripping, tearing sensation.
Aneurysm.
27-year-old tall male, sudden onset shortness of breath, chest pain after sneezing.
Spontaneous pneumo.
Because that back pressure of sneezing popped his lung. The reason why tall, thin males are more at risk for these injuries is because their chest wall is pulled tighter than you and I, so it's pulled tight and it's always under tension. So eventually that aorta may wear out and tear. Their lungs, because of how tall they are, they're thinner and there's less protection below the rib cage where the lungs extend to during breathing. So any back pressure can cause it to pop. Coughing or sneezing can cause it to pop. So anytime they say tall, thin male, sudden onset, chest pain, shortness of breath after coughing or sneezing, that's a spontaneous pneumo. All right? That's a spontaneous pneumo. Those people are prone to spontaneous pneumos. We're not going to do anything for spontaneous pneumo until it becomes a what? What's the first thing that develops when they're turning into a tension? JVD. JVD is the first. Tracheal deviations, the last sign. And remember, the trachea will go opposite of the lung that's injured.
What usually causes the hemothorax? It's just
Blunt trauma.
Just blunt trauma.
Yeah, it could be blunt trauma. Every once in a while, it'll be penetrating trauma, but usually blunt trauma.
Okay.
Is the tension pneumo also obstructive?
Yes.
Okay.
So, a spontaneous pneumo starts out as a hole. A traumatic pneumo starts out, if you stop and think about it. I don't see one in here. If I had a paper sack, all right? This may work. Let's see here. Yeah, this may work. So if you stop and think about your lung, all right? And this is how we get traumatic pneumos. So when I take a breath, this lung inflates, right? And then when I exhale, it collapses. Well, whenever I exhale, if there's no air in it, I can almost hit this thing with a hammer and nothing's going to happen. What happens, though, if you're driving your car, your pickup, and somebody pulls out in front of you? Take a deep breath.
Yeah.
Somebody jumps around the corner, scares you. Somebody pulls a gun on you. So now it's hyperinflated. You hit that steering wheel. You hit that object. Now what happens is I just did what?
Popped it.
I just created a traumatic pneumo. If this hole is bigger than the pinky, it's now going to turn into a tension. Every time they breathe, I no longer have no rise and fall of the chest because the air is going straight through the lung, out the hole into the pleural cavity. That pressure builds up in that pleural cavity, pinches the vena cava, and doesn't allow blood flow back into the heart. That's why it's called obstructive, because it's obstructing blood flow from the vena cava back into the heart. My goal is to put a needle in that chest to where when the air comes through the tube, it has somewhere to escape out of the body instead of creating back pressure. Definitively, what's going to happen is they're going to have to repair this hole in the lung. They may have to tie off one of the alveoli and basically rubber band it and tie it off. They may have to remove part of it. Who knows? But that's ultimately what they need. Our job is to relieve the pressure. Now, 4th or 5th mid-axillary is their primary site now. The reason why is most EMS places were using 2-inch needles. A 2-inch needle is not thick enough to get through my chest wall into my pleural space. But if you go axillary, regardless of how big her breast tissue is, regardless of how muscled up the guy is, when you go axillary, which is actually in the armpit, it's right at the base of the armpit, a 2-inch needle will get into just about everybody's pleural space. The other problem we had with doing 2nd or 3rd mid-clavicular, and I've had this happen to me a few times, is you needle decompress them, they code, and you start doing chest compressions. It's just a plastic flexible catheter that's left in there. We don't leave the actual metal needle. So you start doing chest compressions, and that catheter has a tendency to back out, and then you have to turn around and dart them again. And then after a couple minutes of chest compressions, it backs out again, and then you end up having to dart them again. When you put it 4th or 5th mid-axillary, and they do code, and you have to do chest compressions, it's less likely to end up coming out. So there's some pros to it. It's just kind of a different line of thinking, but if you think about it, if we didn't get anything on 2nd or 3rd mid-clavicular, we went 4th or 5th axillary anyway, so it's not really that big a change. It's kind of a convenience, and the data is showing it's more effective. That's why they made the change. Now, if you intubate somebody and you have absent breath sounds, or not, let me rephrase that. You intubate somebody and you think they have a tension pneumo, and they have diminished breath sounds, JVD, and you dart them, and they don't get any better. And you hear epigastric sounds. That you saw the tube go in the cords. You put your esophageal detector device and it reinflated. You put them on capnography, you have capnography. And you hear breath sounds, but you also hear belly sounds, and you needle decompress them, and they're not getting any better. What has happened is they have ruptured their complete diaphragm. So now because they ruptured their complete diaphragm, you are going to hear them breathing, but because the diaphragm no longer is intact, the air goes straight through the chest into the belly. Does that make sense? Because if you think about it, I'm breathing, but there's nothing there to make it inflate anymore because everything is torn out. That's usually a diaphragmatic and bronchial rupture. These patients will get a ton of subcutaneous emphysema in their belly. And in the male patients, their scrotal sac will fill with blood and air, and it will just start swelling and swelling and swelling like it wants to pop. High chance of death from that because they basically torn their diaphragm that separate their abdominal cavity and their chest cavity.
That's just from that's when their skin basically feels like Rice Krispies.
It feels like bubble wrap. That's correct. That's subcutaneous emphysema.
And that's just from the pressure inside building up. It just ripped all the way down.
It could be, or it could be the bottom of the steering wheel, blunt trauma tore it, something like that. But yeah, it's basically they have torn that diaphragm that separates the lungs and the abdomen to where air's going straight through it. And a lot of times it takes a little while to build up all that air. So a lot of times we'll dart it because it's diminished, they're hard to bag, we think that they're having a pneumo, and it doesn't fix it. So if you think you have a pneumothorax and you dart it, and it's not getting any better, so you go from 4th or 5th mid-axillary to 2nd or 3rd, and it's still not getting better, it's probably a bronchial and diaphragmatic rupture, especially if you hear breath sounds and belly sounds, because the air is just basically coming straight through the body. Does that kind of make sense? It's how you have both. Now, if you have belly sounds only, we're in the wrong hole. If I have right breath sounds only, it's probably right main stem. If I have right breath sounds and diminished on the left and they're starting to get JVD, that'd be a tension. All right? That would be a tension. If I have breath sounds on the right, nothing on the left, and no JVD and no trauma, I put my tube too deep. All right? Hemothorax, nothing we can do for it. Maintain a radial pulse, intubate them if they need it. Ultimately, they need a chest tube to drain and suck all the blood out of the lung.
How big is the hole again from spontaneous to?
It's got to be 2/3 the glottic opening, which is basically 2/3 the trachea. Two-thirds of trachea. If you think your trachea is your first finger, 2/3 of that's the pinky. Not much we can do for a hemo. A spontaneous and traumatic, we won't do anything till it turns into a tension, and JVD is the first sign. Some of the tests will say you had a patient increasing difficulty to bag, they've developed JVD. What do you suspect? Tension. Or they say you have a patient with tracheal deviation and absent breath sounds. Tension. Remember, the trachea goes opposite of the collapsed lung. Myocardial contusion. If they had blunt trauma between the R wave and the T wave, what rhythm can that put them into? VFib or VTAC. What is that blunt trauma called? Commotio cordis. So if it says you have a line drive, softball player, baseball player hitting the chest with a line drive, football player tackles or collapses after being tackled, those are usually indications of commotio cordis. What is the first antiarrhythmic used in commotio cordis? Lidocaine, because it's traumatic and ventricular nature. If it says first drug used in commotio cordis, epi.
Can you repeat that?
Yes. First antiarrhythmic in commotio cordis is lidocaine because it's traumatic defib in nature. If it says the first drug, it's always epi.
Are you ever going to use like amio with that, or you just?
You could. Remember what we talked about yesterday? If you max out on lidocaine, it didn't work, move to amiodarone. Because here's the thing. Yes, we got to be a little careful about giving amiodarone to traumatic defib. But if I give you 3 milligrams per kilogram of lidocaine and you're still dead, I'm going to save your life. I mean, you're dead. So I'm going to try amiodarone. And if it gets you back and you're bradycardic, then I'll deal with that. But, you know, at some point, we have to understand that if they're dead, they're dead. We got to keep trying stuff. And so if I try lidocaine, doesn't work, move to amiodarone. Doesn't work, hell, try MAG as the last ditch. They're dead. They are in defib. Nothing is going to happen until they come out of defib and either go asystole and stay asystole, or they come back alive. We're going to have to terminate that defib one way or the other. All right, so we can move. It's just a matter of what preference of drugs we start with. All right, medical, we could go amiodarone, lidocaine, MAG. Torsades, we could go MAG, amiodarone, lidocaine. Traumatic, lidocaine, amiodarone, MAG. Eventually, we're going to run through them all. Worst case scenario if they stay dead. All right. Pulmonary contusion, bruised ribs are going to get worse before they get better. Pulmonary embolisms. Pulmonary embolisms. Look at your risk factors. Bedridden, prolonged setting, recent surgery, recent long bone fractures. Female smokes, takes birth control. what agency in the Metroplex, as far as EMS goes, do you think sees the most pulmonary ambulances?
Airport.
DFW.
From airlines.
Stop and think about it.
Yeah.
You have a little old lady. She has spider veins, varicose veins. She sits on a plane 6, 7, 8 hours. The pressure's not as great up there to help with circulation as it is down here. And her legs have been bent at a 90 degree. She has those spider veins behind her knee. So she has her legs bent. They swell while she's on the flight because she doesn't have good circulation. She gets up, she walks off the airplane, and she gets down towards the baggage. All of a sudden, she has sudden onset chest pain, shortness of breath. What has she developed?
Pulmonary.
Pulmonary embolism because of a deep vein thrombosis. Now, you have two types of clots that can occur in the legs and arms. You have what's called a DVT, or deep vein thrombosis, and you have an arterial occlusion. So let's stop and think about this. The artery comes out of the heart from the aorta, goes to the arterioles, goes to the capillaries, exchanges O2 and sugar, picks up the acid, moves out of the capillaries to the venules, to the veins, and goes back up to the vena cava. If I develop a clot on the arterial side, it's not going to let any red, warm oxygen or sugar go past that damage. So guess what color and temp that leg would be?
Cool.
It'd be cool, it would be pale, and it would have no pulse. Or an extremely weak because there's no arterial blood flow coming into the leg. So if it's cold, pale, weak pulse, that's an arterial occlusion because there's no blood able to come into the leg. A deep vein thrombosis, on the other hand, what ends up happening, blood comes in through the artery, goes to the capillaries, exchanges oxygen and sugar, picks up the acid, starts working its way back through the vein, hits that clot. Well, I still have red, warm blood coming into the leg, but I'm not allowing it to what? To leave. So that leg's going to become red, hot, and swollen because blood keeps getting pumped into there. Once this clot breaks loose, the further away you get from your extremities, what happens to your vessels, your veins?
Get smaller.
It's small, and as you move back to the heart, they get bigger. So basically, this clot, when it forms here, if it breaks loose, it's a highway straight back to the heart because the vessels are just going to keep getting bigger and bigger and bigger the closer it gets. Versus the arterial side, when it leaves the aorta, everything gets smaller as it goes. So an arterial occlusion is not likely to cause a pulmonary embolism because think of what would happen. If I formed a arterial clot behind my knee, all right, the arterial side, it would have to move all the way down to my foot, go through the microscopic capillaries, from the microscopic capillaries to the venules, to the veins, to the vena cava. Not likely, because it would have to be microscopic in order to get all the way through the capillaries, because that's the smallest part of the circulatory system. Versus a venous side, once it breaks loose, the vessels get bigger and bigger the closer we get to the heart, so it's like a super highway to carry that clot back up. Arterial occlusion will cause damage to the leg, but not likely to end up creating a pulmonary embolism. A deep vein thrombosis, on the other hand, when it breaks loose, is more likely to cause a pulmonary embolism. Depending on where it gets stuck, once it breaks loose, will determine whether or not they have RELs in pink frothy sputum. So, let's stop and think about this. You run to the love field. All right, you run to love field. Little old lady exits the plane. Her leg is red, hot, and swollen to the touch. She has a deep vein thrombosis. What do we need to do to that deep vein thrombosis? Immobilize it. Why?
So it doesn't break loose.
So it doesn't break loose. So we immobilize it. We put her on the cot, and we decide that we're gonna run her down to, I don't care, Clemens, Parkland, wherever. So you're on your way down to Clemens, or UT Southwest, I guess it's called now. You're headed down there, and all of a sudden she becomes cool pale, short of breath, and she starts developing fluid in her lungs.
Is it broke loose?
What has happened?
Broke loose.
It broke loose and it's gone up. What side of the heart is it lodged on?
It's gonna be on the right side.
On the left. Because if it's lodged on the left, when the blood comes in the left atrium and the left ventricle, that clot is blocking it, so it will back up and have a CHF presentation. If it got lodged in the right ventricle or the pulmonary arteries, no blood can go past it to the lungs, so she would be short of breath. Lungs would be clear though, because I'm not filling them up with blood, and the blood would go backwards and cause jugular vein distension. Just like yesterday, left-sided heart failure backed up in the lungs, right-sided heart failure backed up to the rest of the body. That same thing will occur if that PE breaks loose. Risk factors is the biggest thing. 67-year-old male, cross-country bus ride, sudden onset, chest pain, shortness of breath. You should suspect a what? PE, because what's a cross-country bus ride do? Elderly sitting down can end up forming clots in the feet. 42-year-old female smokes a pack of cigarettes a day, takes birth control, sudden onset, chest pain, shortness of breath. PE. 19-year-old male snow skiing, broke his femur 2 days ago. Sudden onset, chest pain, shortness of breath. PE, long bone fracture. Long bone fracture. All right. 32-year-old female gave birth to a healthy newborn 3 days ago, had cesarean, sudden onset chest pain, shortness of breath today. PE. 32-year-old female gave birth to a healthy baby 3 days ago, sudden onset fever, low BP, and rash. Sepsis. There you go. Petechiae is a rash that occurs with sepsis. If females have problems after delivery, it is one of three things. It's either a pulmonary embolism, an infection, or every once in a while they can develop preeclampsia and eclampsia post-delivery. They can have postpartum high blood pressure and it clogged their kidneys. Yes?
So with the two differentiating, like sepsis and the PE, the pregnant patient, which is that kid, would it be surgery, C-section versus non?
Yeah. Yeah, C-section versus non.
If you're differentiating just like a normal CHF patient and then someone with the left side of PE, is this primarily going to be history?
History. Yeah, history.
Every patient doesn't have a clue.
Right. There's a reason why, if you think about yesterday, 56-year-old male, sudden onset chest pain, shortness of breath, sitting on the couch. 56-year-old male mowing the yard for angina. 56-year-old male cross-country flight.
So they're going to put something.
They have to
specific.
put something in there. They got to put one of those risk factors as a descriptor. If they don't, then we're never going to be able to figure it out.
Yeah.
You know, and that's what we have to look for, Montez.
The PE, the little clot, does it get stuck in? I mean, I know it makes sense because it would be the lungs because that's what it's fucking called. But
Well, it actually gets stuck in the pulmonary arteries
right.
going to the lungs or the pulmonary veins coming back from the
Okay,
lungs.
so it's not in the actual lungs.
Not typically. It's usually in the vascular system going to it.
Okay.
It's not like it's on top of the alveoli. It's actually in the vessels going to and from the lungs from the heart.
Okay. Yeah, that makes sense.
Okay? PE, all we can really do is tilt them up on the bed about 45 to 60 degrees and turn them on the left. If it's an air embolism, air always goes to the what? To the top. If it's fat, it has a tendency to float. If it's a fat embolism that broke loose. So by tilting them up and turning to the left, we're hoping to keep that right atrium elevated to where if it is an air bubble, it will rise to the top of it and not get sucked down into the pulmonary arteries or pulmonary veins. And it makes us feel like we did something because we really can't do shit for them. All right? Definitively, they're going to have a thrombolytic and heparin, and a lot of times they'll put a screen in their pulmonary veins or arteries that acts like a screen to catch and basically dissolve and cut that clot up. A lot of times this is what they'll have to do. For us, the key is risk factors. They got to put one of those risk factors in there. Not much we can do about it. Sucking chest wound, how should you immediately take care of it?
3-sided inclusive.
Immediately.
Locaine.
Okay, and then we look for our 3-sided occlusive dressing. What is the corner we leave open called? Flutter valve. If they start becoming difficult to bag and develop a tension pneumo, what should we do with it? Dart it. What do you try first? Burp it. Use the hole you got. Burp it, and if that didn't work, then we'll need to decompress it. But try the hole you got. How could they end up having a hole in their chest, but we're not able to relieve pressure from it? So if this is my outer layer of skin and I'm bent over and something goes in me, when you put me on a board, it's going to shift, and that underneath dermis and epidermis layer will slide and can end up shutting off airflow in and out of that. So it basically seals itself from the movement and shifting of the tissue, and that's how that sucking chest wound can end up sealing itself. Does that kind of make sense? We're going to try the hole we got first, and if that don't work, then we'll go ahead and needle decompression.
We'll have the subcutaneous emphysema.
They may. They're going to give you the same signs and symptoms of a tension. So if I have a stab wound, gunshot wound to the chest, and they develop JVD and difficulty bagging, that sucking chest wound is turning into a pneumo. Burp it, doesn't work, dart it. What are the terms for darting the registry can use?
Pleural decompression.
Pleural decompression, needle decompression, needle thoracentesis. Centesis means needle introduction, thorough means thoracic cavity.
Wow, that's like
Just like we had pericardiocentesis, which was a needle introduction into the pericardium. Centesis means needle introduction. Thoracic would mean thoracic cavity, thoracentesis. So pleural decompression, needle decompression, or thoracentesis is a needle into the chest. 14 gauge, 2 inch at least. Traumatic asphyxia, most of these people are dead, but they may not be. It comes back to the paper bag theory. They're driving down the road, car pulls out in front of them, take a deep breath, hit the steering wheel. They hit the steering wheel, it pops their lungs. Their vehicle is going to move until it's stopped. Once the vehicle stops, the body's going to keep moving until it's stopped by the seatbelt, airbag, or steering wheel. And the body's going to keep moving until it's stopped, and then the aorta and internal organs are going to keep moving until they're stopped by the rib cage. What ends up happening in traumatic asphyxia is not only do they rupture their lungs and their bronchioles, but a lot of times from the movement of the organs forward and then back, it will tear the aorta. And when it tears the aorta, all the blood from the upper body runs in the lower body, which is why they're blue from the nipple line up a lot of times. And they had so much pressure when they that it will make their eyes bug out of their head a little bit. You may even see some bleeding from the eyeballs. No, not machete. So that's a traumatic asphyxia. Most of them are dead before we get there. If they have signs incompatible with life, pulsus and apneic, we're not going to work. We talked about head injuries yesterday. What makes the pressure go up in a head injury? What nervous system and what drug?
sympathetic epi.
And an epi, what parts of epi? The alpha, the vasoconstriction, because remember, we are trying to squeeze blood past that injury. When we get too much blood in the cranial vault, it pushes down on the brainstem. When it pushes down on the brainstem, the body tries to protect itself. It protects itself by drawing up. If I walked up and was to shove an object in the back of your neck, what are you going to do? Ow! Come up towards the cord. That's why they get decortic posturing. As they get 50% herniation into the midbrain, they get disseverate posturing and go out. That's why on our GCS, when we look at the motor side, 3 is decortic, 2 is deceberate, and has a higher chance of mortality because they're almost 50% herniated. That's why it has a 2 on the GCS. If we look at the motor side on the GCS, it was 6, 5, 4, 3, 2, 1. 1 is always none. 6 is perfect. Localized, withdrawal, decorticate, and deceberate. That's why it gets a 2, because they're 50% herniated. The other thing that happens is that the medulla is your respiratory pons in your chemoreceptors. Your chemoreceptors measure carbon dioxide. If the carbon dioxide level's too high, they'll tell you to speed up to blow the acid off. If the carbon dioxide level's too low, they'll tell you to slow down. Because there's pressure on the chemoreceptors and they don't get adequate blood flow, they don't know whether the CO2 is high or low, so they do what?
They breathe
Both.
in fast.
Fast and slow, that pattern is called what?
Cheyne-Stokes.
Cheyne-Stokes. Our biggest goal in a head injury, first of all, is to recognize it, pay attention to Cushing's, IBP, low heart rate, irregular respirations, protect the airway, prevent hypotension. Why would I say prevent hypotension? Let's stop and think about this. If it's taking a pressure of 180, 190, 200 to keep the brain alive, what happens if that pressure gets below 90? There is nothing past the injury to keep the brain alive. So we want to protect the airway and prevent hypotension. 99% of the time when we're with them, the pressure is going to be extremely high. But if it does fall, we're going to have to give them some fluid. All right? We also avoid high flow oxygen in them. You need to know the difference between a epidural or subdural and subarachnoid bleed. An epidural is fast onset. They fall, hit their head, get knocked out for a second or two, they come back and they know everything that happened. So it's like I hit my head, days, I'm like, holy shit, that hurt. You all right? Yeah, I'm all right. And then 30 seconds to a minute later, they're unconscious and dying because it's an arterial tear. It's also called severe diffuse axonal injury. If I remember correctly, we're probably coming up on 4 or 5 years ago now. One of y'all's guys around Thanksgiving was playing soccer with his daughters down at South Padre, fell and hit his head on the sidewalk, came back up, said something to his wife and girls, and then immediately ended up having a head bleed, and that was an epidural, right? I think it was probably 3-4 Thanksgivings ago now. But that was an epidural. Fall, hit your head, pass out for a second, come back, and then within a minute or two, you're basically dead from the amount of blood that's inside the brain. A subdural, on the other hand, is a mild diffuse axonal injury, and it's really slow. It's usually venous. So what's going to happen in a subdural bleed is they're going to lay flat, and they're going to get a severe headache. And when they set up, the headache's going to go away. Why?
Because the blood's easier flow path.
When they lay flat, the blood pools in the brain. When they set up, gravity pulls the blood out of the cranial vault. The pressure goes away. Anybody that's having a headache, what test do we need to do on them? Cincinnati. Stroke. If they're having a headache, do a stroke test, because that lets us know if they're having a perfusion issue in the brain. So have them say something silly, have them squeeze your hands, have them Superman, and have them smile. All right? Say something silly, squeeze, smile, and Superman. All right? If those are positive, then we have a neurological cause of the headache. Could be a bleed, could be a stroke. So any person with a headache, do a stroke test on them. All right? Do a stroke test. If they have a headache when they lay flat at night and then it gets better when they get up and go to work, and then it's back when they lay down at night, that's usually a sign of a slow bleed. And that can be like that for days to weeks. All right? And then a subarachnoid a lot of times will have a clap. a thunderclap, they'll hear it pop, all right? The person will be sitting there and they'll hear something pop, or they'll get in the head and they'll say it hurt, it sounded like thunder, or a gunshot went off in their head. That's a subarachnoid. That's a moderate diffuse. That has a medium chance of mortality. All three of those will manage the same way. Why does a head injury vomit, like projectile vomit?
To relieve pressure.
To relieve pressure. When I vomit, I throw up fluid. That's going to help lower the pressure. Also, when they projectile vomit, what lies between the esophagus and the carotid artery? Vagus nerve. So when they vomit, they also stimulate the vagus nerve, which will drop their heart rate. They drop their heart rate, they lower the pressure. The other thing they're throwing up is acid. A head injury will be respiratory acidosis initially for two reasons. They're vasoconstricting their extremities, so they're stealing all the oxygen from their extremities, so their extremities are becoming respiratory acidosis. Their brainstem can't measure oxygen and CO2 levels correctly, so they can't blow off the increased acid. So they're going to be respiratory acidosis, and if they stay like that for 10 to 20 minutes, they'll become metabolic acidosis. Well, when I throw up vomit, I'm also throwing up stomach acid to help regulate the pH. So that's why they get that profuse exercise projectile vomiting. The problem is they're altered, so they're not protecting their airways, so they're at risk for aspiration. So what's a good thing to compensate for pressure and acidosis is a horrible thing, because now they're at risk for aspiration pneumonia if they get the vomit in them. So it's kind of like, well, darned if we do, darned if we don't. Remember our breathing rates from yesterday in head injuries and strokes? 12 to 16, 16 to 20. You can go to a max of 24 if you have what device? Capnography.
Can you explain the baseline for that bicarb again, the 22 to 26? Anything outside of that? Is
Metabolic. Then move on.
Acidosis?
Or it could be alkalosis.
Okay,
It depends on your pH.
Okay.
So if pH is alkalotic, it's above 7.45, and bicarb's out of whack, metabolic alkalosis.
Okay, so that just says metabolic.
If I'm below 7.35, I'm 7.32, bicarb's out of whack, metabolic. If bicarb's normal, then it's respiratory. And then pH will tell me whether it's alkalotic or acid.
It doesn't matter on bicarb if it's high or low.
Don't get into that. That's just more shit put in your head and confusion for now.
Are you gonna see the unequal pupils in both of those?
Yes. In all three of the bleeds, you may see unequal pupils depending on the pressure.
Okay.
Size of that whiteboard that you're talking about, like
A little bit bigger than a sheet of paper. It's like 11 by 13.
Okay.
Think of it like a legal pad.
yeah.
They give you a marker.
They give you a marker.
So you can't write it.
You can't erase.
One of those.
Yeah, they give you a big chief tablet. You don't even know what that is. That's how I learned to write in kindergarten, was big chief tablet with dotted lines on the paper. All right, page 5. Blunt trauma to the abdomen. Whatever is on the outside where the bruise or the wound is, we have to consider the organs underneath. Our stomach contains two categories of organs, solid and hollow. Solid organs have what's called somatic pain, all right? So a solid organ has somatic pain because there's always blood in them, which means the pain is constant, all right? So if it says 27-year-old male, right upper quadrant, complaining of somatic pain. Somatic means constant. Constant pain is related to solid organs because there's always blood in there. So what is the solid organ in your right upper quadrant? Liver. Visceral pain, on the other hand, occurs in hollow organs, and because the organs are hollow, it only hurts when food or bile or something is scraping the insides of that organ. So visceral pain in the hollow organs is going to be crampy and colicky. It's going to cramp and come and go, and it's going to feel like it's moving because the food or the alcohol or the fat is what? Shifted. So it's going to be poorly localized, crampy colically, comes and goes, and it's going to be worse after greasy, spicy, fatty foods. Now, in trauma, the solid organs are my number one concern because they can cause what? Hemorrhagic shock. If you survive hemorrhagic shock, 3 to 7 days later, your hollow organs may give you what? Sepsis. Because when a hollow organ ruptures, it ruptures all the bacteria, the food, the bile, and all the shit that's in there. So, you have a car wreck, and this is what they'll word it. You have a frontal collision MVC, 27-year-old male, right upper quadrant, somatic pain. You should suspect what type of shock? Hemorrhagic, spinal, septic, or hypovolemic? Hemorrhagic because it's a solid organ and they can bleed. You have a car wreck, 27-year-old male, frontal collision. He has poorly localized right upper quadrant pain that is visceral in nature. What is your primary concern?
Spleen?
Hemorrhagic, sepsis, hypovolemic, or neurogenesis?
Sepsis.
Because it's the hollow organ and gallbladder. Solid organ right upper quadrant liver, solid or hollow organ right upper quadrant gallbladder, left upper quadrant solid organ spleen, left upper quadrant hollow organ pancreas. The solid organs will make you bleed to death. If you survive that, then you'll get sepsis 3 to 7 days later. Our primary concern is solid organs because of hemorrhagic shock. Secondary concern is the hollow organs because of sepsis. Some other things that go with abdomen terminology. What if I said 27-year-old male, frontal collision, MVC with Cullen's sign? C-U-L-L-E-N apostrophe S. That is bruising around the belly button. That is sign of intra-abdominal hemorrhage. You may also hear it called para-umbilical ecchymosis. Ecchymosis meaning bruising. Para means circle around the umbilicus. Around the belly button.
What organ would that be?
It's usually just internal bleeding in the intra-abdominal cavity. Blood's gotten in there from somewhere. And it basically makes a bruise around the belly button.
How late do you see that?
Pretty late.
Pretty late.
Yeah. But it's just one of those terminology things. What if I said you have a 27-year-old male lateral MVC, which means he was T-boned, and he has gray Turners on the left side. Gray Turners is bruising over the flank. That's indicative of a kidney injury or kidney laceration. If I was to say you have 27-year-old male, nausea, vomiting, diarrhea, cool, pale, clammy, and he has McBurney's point. That is tenderness over the right iliac crest on rebound, indicative of the appendix. So they're going to use some terminology like that where they give you a word and you have to figure out the disease process. What if they have Rosmans and psoas? Psoas is when they push on the left side, it makes the right side hurt. Rosmans is when they flex their leg, it makes the right side hurt. Those are both indicative of appendicitis. What if it says 27-year-old female, frontal collision, MVC with hematuria and lower abdominal pain? What is hematuria?
Confident blood.
Piss and blood.
Piss and blood.
Hematemesis, throwing up blood. Hema is blood. So hematemesis is throwing up blood. Hematuria is peeing blood. Hematochezia, bloody cheese, is shitting blood, bright red blood. Melena or melena is dark tarry blood that tells you it's been processed by the stomach. If it's dark and tarry, the blood has gone into the stomach acid and gelled. If it's bright red, it's below the stomach. It's below the gastrointestinal, which is hematochezia. What if I said you have 47-year-old homeless male with hemoptysis and weight loss? What device should you wear?
995.
Hemoptysis is coughing up fever, night sweats is TB. You need to wear it in. Does it go on you or the patient?
On me.
On you, perfect expert.
That's first.
Non-rebreather, blow it back in their face, N95 on you. All right? So that's how those terminology words may be interjected. All right? Hemorrhagic shock, maintain a radial pulse, which is pressure of 80. Take them for surgical evaluation. Hollow organ damage, take them for surgical evaluation. A lot of times what happens at trauma centers with abdominal injuries is they'll go in, when they get there, they'll do surgery, and they'll find the bleeders, and they'll fix them. 3 to 4 days later, a lot of times they have to go back into them and clean the bowel and stuff out because an infection has developed. So initially, they'll go in and they'll stop all the bleeding, take care of the hemorrhage, and then a lot of times they'll have to go back in and clean it out again because either blood's been left in there or maybe some bile or something's gotten left in there, and they start becoming sepsis. So that's why a lot of times your abdominal injuries require multiple surgeries. Usually to stop the bleeding and then another couple to go in there and clean out the infection is usually what ends up happening. All right, injuries to the neck. You can use direct pressure if you have a laceration to the neck. If you have a laceration to the jugular vein or the carotid artery, you can use direct pressure, also use an occlusive to where they don't get an air embolism and sucked in. When we do direct pressure, we're only doing one side. We're not there to choke them, all right? If we put pressure on one side, they can still get blood through the other side because of the circle of what? Willis. Yes.
Is there ever a point where we're gonna pinch, like if it's a clean slice?
You may have to, which would be technically direct pressure. The one that kind of comes to mind is the hockey player where he fell and the blades got him and they basically were like pinching it and holding it together. You may have to if it's that clean. So, but what the PROC is going to say is direct pressure and an occlusive to prevent air from getting down in there. If the air gets down in there, they'll have upper chest and neck subcutaneous emphysema or the bubble wrap. All right. Any questions over that? All right. Take 10 minutes. Come back in. We'll do airway.